Hello everyone, welcome to LDL. I am Dr. Adarsh Pal, Senior Resident in Neurology at NIMHANS. Today we are tackling one of the most underdiagnosed and mismanaged conditions in neurology, IIH, Idiopathic Intracranial Hypertension. What makes IIH dangerous is this. It looks like a headache, it gets called migraine, it gets sent home, and quietly without anyone noticing, it steals the patient vision. We are going to fix that today through 5 real clinical cases. In MCQ based discussion, 5 cases will represent classic representation, drug induced, monitoring pitfalls, surgical decisions, and the dangerous mimic that kills if you miss it. So let's start. Alright, case 1. Read this carefully. 28-year-old woman, obese, BMI 34. 3 months of daily headaches, pressure like worst in the morning and whenever she bears down. Valsalva makes it worse. Red flag. She also gets brief episodes of blacking out in the both eyes when she stands up quickly, transient visual obscurations, and a whooshing sound in her right ear in sync with her heartbeat, pulsatile tinnitus. No fever, no focal weakness, no meningismus. Fundoscopy reveals bilateral papilledema, but her vision is still 6/6. MRI partial empty sella, posterior globe flattening, no mass. On lumbar puncture, opening pressure is 32 centimeters of water, CSF is completely clear, normal cells, protein and glucose. Young obese woman, daily headache with TVOs, LP32, bilateral papilledema. The question is, what do you do next? The 4 options are, you need to pause and genuinely think before moving on. The first is dexamethasone IV, B. Estrazolamide plus weight loss plus close visual monitoring. C. Go straight to lumboperitoneal shunt. And D. Reassure, start migraine prophylaxis and review in 3 months. One of these is actively harmful in IH, one will waste critical time, and one is the right answer. The correct answer is estrazolamide, weight loss and close visual monitoring. This case fulfills all 4 modified Dandy criteria. Symptoms of raised ICP, lumbar pressure over 25 centimeters of water, completely normal CSF, and no structural lesions on MRI. That is idiopathic intracranial hypertension. Estrazolamide is the first line drug. It inhibits carbonic anhydrase in the choroid plexus and thus reducing CSF production. Weight loss is non-negotiable. Even 5 to 10% reduction in body weight directly lowers jugular venous pressure and ICP. It is the only truly disease-modifying intervention. Now the traps are, option A if we consider steroids. This is the most dangerous distractor. Glucocorticoids do absolutely nothing for IH. Guidelines explicitly say do not give them, even when vision is acutely threatened. Never give dexamethasone for IH. Option C is shunt. Surgery is for vision-threatening papilledema that fails maximum medical therapy. This patient's acuity is preserved. Option D is migraine prophylaxis and come back in 3 months. This will not do because we know patient has bilateral papilledema and an LP of 32. Treating this as migraine risks permanent blindness. So most critical takeaway is monitor visual function at every single visit. We need to monitor visual acuity, color vision, perimetry and OCT. The greatest threat in IH is irreversible blindness. Do not let it creep up. Let's go through the clinical reasoning more carefully. The headache pattern is diagnostic. Pressure like worst in the morning because ICP is highest when lying flat overnight. So mornings are characteristically bad. It gets worse with Valsalva. Any maneuver that raises venous pressure transiently worsens ICP. Transient visual obscurations occur in about 68% of IH patients. The mechanism is that optic nerve is already congested and swollen. Any sudden positional change causes transient ischemia to the tiny vessels supplying the nerve. It leads to brief blackout and then recovery. It is painless. Patient can also have pulsatile tinnitus. Papilledema occurs in 95% of the cases. The key point here is that you have to look at the fundus to identify papilledema. However, you cannot rule out IH just based on absence of papilledema. You need to do MRI to exclude mass lesions, hydrocephalus and venous thrombosis because it is idiopathic intracranial hypertension. So you need to rule out other causes of intracranial hypertension. Signs of raised ICP include the sella would be empty, there would flattening of the posterior globe, optic nerve sheath distension would be there. So the CSF fluid surrounding the optic nerve, it would appear more. Transient transverse sinus stenosis would be there, which is present in about 94% of IH. Whether it is the cause or the effect, it is debated. A very important tool is OCT of the retinal nerve fiber layer. It is the most sensitive monitoring tool. Now let's review the management in brief. The first important is estrazolamide, which lowers the ICP by inhibiting carbonic anhydrase. We need to monitor for its side effects, which are hypokalemia, metabolic acidosis, as well as paresthesias. The second important step is weight loss. 5 to 10% reduction meaningfully lowers ICP. If the lifestyle measures are not enough, then the bariatric referral may be warranted. The third is monitoring, which is the most important thing. We need to monitor for visual acuity, color vision, visual fields by perimetry, as well as objective measurements by OCT, in which we measure the retinal nerve fiber layer thickness. And fundoscopy is also important. However, fundoscopy alone is not enough because the early changes are missed without the OCT. If the papilledema is threatening vision despite maximum medical therapy, then we need to escalate to surgery. We'll discuss about that in further case. So the key point is, papilledema is the cardinal sign in 95%. However, OCT retinal nerve fiber layer is your most sensitive monitoring tool, which we need to use it. Let's see the second case. A 17-year-old teen, normal BMI, 6 weeks of progressively worsening headaches and blurred vision. She has been on oral isotretinoin 40 mg per day for acne for 2 months. Fundoscopic examination reveals bilateral papilledema. There is no meningismus, no focal neurological deficits. MRI reveals no mass, no hydrocephalus. However, posterior globe flattening is noted. LB pressure is 29 centimeters of water, which is raised above the cutoff of 20 centimeter. CSF reports are completely normal. She meets the IH criteria. What do you think it is? And what would be the single most important management step? Option A is continue isotretinoin. Headache is coincidental and start topiramate. Option B is stop isotretinoin immediately and start estrazolamide and take ophthalmological review. Option C is IV MPS and option D is urgent CT and neurological shunt. One of these addresses the actual cause and one is the steroid trap again and one risks permanent optic nerve damage. So what do you think is the correct answer? The correct answer is stop isotretinoin immediately. We need to start estrazolamide and we need to take an urgent ophthalmological review. Isotretinoin and other drugs like doxycycline can cause IIH, drug-induced IIH or secondary IIH. So we need to remember that. The second is urgent formal visual assessment is required, which includes perimetry and OCT retinal fiber layer as well as looking for papilledema. However, fundoscopy is not enough. We need to understand that we need to do perimetry and OCT RNFL to detect the changes early. The first option, that is continuing isotretinoin. If we'll continue isotretinoin, it risks progressive silent optic nerve damage. Therefore, it is a wrong option. And third option is steroids again. Steroids have no role in IH. And the fourth is perform urgent CT head. However, we have already performed MRI in the case scenario. So the CT would not give any extra benefit. The key takeaway from this case is that we should take a good drug history. The drugs implicated in secondary IIH are retinoids like isotretinoin and acetatin, as well as high dose vitamin A, and tetracyclines like minocycline and doxycycline. So management of drug-induced IIH is, one, we need to stop the drug, and the rest of the management is similar to as we discussed previously. Now let's see the third case. 32-year-old woman with confirmed IH. She has been given acetazolamide in adequate dose. On OCT, papilledema has resolved. That means that the treatment is working. But she comes back worse. She is complaining of persistent daily headaches. On detailed history taking, she is using codeine almost every day for pain relief. And she also reports fingertip tingling. On examination, vision is 6 by 6. Investigations show perimetry is normal. Labs bicarbonate is 17, that is slightly low, and potassium is 3.2, which is low. She asked, Doctor, my eye pressure is better. Why are my headaches still so bad? So what do you think is the most likely explanation for a persistent headache? Option A, ICP remains elevated despite resolving papilledema, so we need to do repeat LP urgently. Option B, estrazolamide induced metabolic acidosis causes cerebral vasodilation and causing headache. Third, pressure independent migraine with superimposed medication overuse headache is responsible for this patient's persistent headache. Or fourth, optic nerve fiber loss is causing referred headache, therefore we need to perform urgent surgery, that is optic nerve fenestration surgery. What do you think is the right answer? The key point is, and the correct answer is, that the pressure independent migraine combined with medication overuse headache is causing the patient's persistent symptoms. There is one concept that IH, headache and papilledema do not correlate. That means that the papilledema may resolve, however the headache may persist. Why? Two reasons. First, there may be central sensitization. So chronically elevated ICP bombards the trigeminal pain pathways and they become sensitized. So even when the ICP is normal, the patient can have headache. That is pressure independent headache. And second is the patient is using codeine tablets almost daily. So when we use codeine or Naxdrom, that is naproxen, daily, it causes medication overuse headache. So these two things are responsible for patient's persistent headache. If we see the other options, first is repeat LP. The LP opening pressure does not correlate with headache severity or visual loss in IH. Therefore, there is no indication to repeat LP for monitoring. For monitoring, as we have learned previously, OCT is the tool where we measure retinal nerve fiber layer thickness. Second is metabolic acidosis from estrazolamide. This explains the fingertip tingling. However, this does not cause the headache. The fourth option is optic nerve fiber loss leading to referred headache. However, there is no indication of surgery because OCT is improving, perimetry is normal, there is no damage happening. Optic nerve fenestration surgery is for vision-threatening papilledema. It is not indicated just for headache. So this case teaches a principle that changes how you manage IH in the long term. Headache management in IH is a separate clinical problem from ICP management. When papilledema has resolved and vision is stable, you have to manage what is essentially chronic migraine with central sensitization. So how to look for central sensitization? The patient will tell that their scalp is tenderness, or when combing hair, the patient will feel pain. So that means that the central sensitization is there. And other thing is medication overuse headache. So we need to ask whether they are taking painkillers like triptans, codeine, NSAIDs more than 10 days a month. That can cause medication overuse headache. And we need to monitor using OCT, retinal nerve fiber layer thickness. Now here is an interesting point. If the retinal nerve fiber layer thickness is decreasing, it can mean two things. Either there is a response to therapy and therefore ICP is lowered and hence the thickness is decreased, or there is a loss of axons of the optic nerve, which is a bad thing. So how to differentiate between these two? We use ganglion cell inner plexiform layer thickness to distinguish between two. So ganglion cell inner plexiform layer will be normal if the ICP is improving, that is it is normalizing, and it will get reduced if there is a real axonal loss. The management we have already discussed that we need to withdraw the NSAIDs, opioids or codeines so as to avoid the medication overuse headache and then treat as migraine, and surgery is not indicated for just headache alone. 35-year-old woman already on maximum medical therapy. She is also doing lifestyle modification, that is she had achieved 8 kg weight loss. She should be improving. Instead, her papilledema has progressed from grade 2 to grade 4 on the Friesen scale. She now has a new inferior arcuate scotoma on perimetry. Her visual acuity has also dropped 6 by 12 in the right eye. This is 2 lines lost on the Snellen chart. MRI and MRV shows bilateral transverse sinus stenosis with a pressure gradient of 8 mm Hg across the right transverse sigmoid junction. We do a LP and pressure is raised 36 centimeters of water. There is no contraindications to antiplatelet therapy. Which surgical option do you think most directly addresses the pathophysiological mechanism? So let us see the options. First is lumboperitoneal shunt, which most reliably causes acute reduction in ICP. Second is optic nerve fenestration surgery, which protects right eye vision locally. Third is dural venous sinus stenting, which targets the underlying stenosis driving raised ICP. And the fourth is VP shunt, which preferred over LP shunt due to lower revision rate. What do you think is the correct answer? Which of these surgeries addresses the pathophysiological mechanism? The correct option is dural venous sinus stenting. Let us understand the pathophysiology. In IH, particularly with obesity, elevated jugular venous pressure is transmitted into the intracranial venous sinuses. Now, when the intracranial venous sinuses pressure is raised, CSF absorption across the arachnoid granulation is reduced, and therefore ICP rises. This raised ICP then again compresses the transverse sinuses at the transverse sigmoid junction. So it creates a functional stenosis. This stenosis again worsens venous outflow and therefore worsens CSF absorption, which further raises ICP. So this becomes a positive feedback loop, raising ICP. What we do in venous sinus stenting, we place a stent across the stenotic segment and thus breaking that loop. Venous outflow is restored and CSF resorption resumes and ICP drops. Option A, LP shunt, is very effective at lowering ICP and it is also most reliable. But 20 to 40% revision rate is there and does not address the venous mechanism. Option B, optic nerve fenestration surgery, protects the ipsilateral optic nerve locally and acutely. It is a good option for immediate vision protection. However, it does not lower global ICP and therefore headache, tinnitus, diplopia, and the contralateral eye problems all persist. VP shunt has similar revision rates to LP shunt. However, it is more invasive and not specifically preferred for IIH. The key distinction is stenting treats the cause, the other manages the consequence. The most important takeaway from this case is when to do a surgery. So the two absolute indications for surgery is that the papilledema, grade 4 papilledema, that is worsening on maximum medical therapy, and the second is patient is having acute visual loss. So either of the two justifies the need for surgery. And then with the discussion with the patient and the neurosurgery team, we can decide which procedure would be most useful for the patient. Now let's see the last case, which shows a dangerous mimic of IH. A 26-year-old obese woman on the combined OCP presents with 10 days of progressive headache, worst headache of her life. It is not chronic, not long-standing, and it is getting worse over 10 days. On examination, we observe bilateral papilledema. So at first we think whether it is IH, but then we also see left 6 nerve palsy and GCS of 14 and a left arm weakness. This arm weakness, focal cortical deficits, these are something which we have not seen in IH. MRI was showed right parasagittal hemorrhagic infarct. Magnetic resonance venography showed filling defect in the superior sagittal sinus. LP showed elevated pressure 34 centimeters of water. But CSF is not normal here. There is xanthochromia for 480 RBCs per millimeter cube. So what is this? What is the correct diagnosis? And what is the immediate management priority in this case? So option A, do we diagnose this as IH and treat it with estrazolamide and repeat LP in 1 week? Option B, is this a case of cerebral venous sinus thrombosis and we need to start anticoagulation urgently? Option C, is this a subarachnoid hemorrhage and we need to do CT angiogram and send a neurosurgery referral? Or it is just an hypertensive encephalopathy and we need urgent BP lowering and ICU admission? What do you think is the correct answer? The correct answer is CVST, that is cerebral venous sinus thrombosis, and we need to anticoagulate with low molecular weight heparin urgently. CVST can mimic IH because both will give raised ICP, papilledema, and high LP opening pressure. However, an MRI can differentiate these two. And also clinically, CVST would have red flags like there are focal neurological deficits, that IH patient does not have, like arm weakness, aphasia, hemiplegia, and reduced consciousness level. And also the CSF would not be normal. It might show blood, that is xanthochromia, and MRI shows filling defect, an actual clot, not just narrowing like stenosis seen in the IH. So if we see the other options, first option is idiopathic intracranial hypertension, which is wrong answer because the clinical and MRI findings are not compatible with IH. The third is subarachnoid hemorrhage. So here we find a filling defect in the MRV, and this confirms the diagnosis of cerebral venous sinus thrombosis. The fourth is hypertensive encephalopathy. In the hypertensive encephalopathy, the MRI changes show hyperintensity in the posterior occipital lobes, and this case does not has that, so it does not fit in this scenario. So what does this case highlight? This case highlights that when you have red flags, then the neuroimaging becomes very important, because there could be IH, but there could also be CVST, there could be a mass lesion which can only be identified on the MRI. The clues can be if there are focal neurological deficits, then you have to do an urgent neuroimaging. And also the other clue was that this patient presented with thunderclap headache, which was of short duration. So short duration severe headache is also an indication for neuroimaging. So briefly seeing the management of CVST, the most important thing is anticoagulation. Even if there is hemorrhagic infarction, we need to start anticoagulation, and this may sound contradicting, but this is true, that evidence favors anticoagulation. And we need to stop prothrombotic things like OCP, and the supportive management includes ICP management. And if this fails, then we need to go for endovascular thrombectomy, where through endovascular approaches, we remove the thrombus, or local thrombolysis we do. So young obese women, high pressure headache, headache worsening with coughing, straining, examination showing bilateral papilledema, suspect IH, do MRI, do CSF pressure more than 25 centimeters, shows raised ICP, diagnose IH and treat with medical therapy or if needed surgical interventions. Always ask for drug history, because drug-induced IH can occur, in which stopping the drug can be curative. Third, monitoring is important. We just can't monitor with a headache, because headache does not correlate with ICP. We need to monitor with visual acuity, visual field, papilledema. The most important thing is retinal nerve fiber layer thickness by OCT. We also need to understand that persistent headache can be due to medication overuse headache or central sensitization. Surgery is indicated for vision-threatening papilledema, and there are various approaches that the surgeons and the neurology people and the patient can discuss for deciding which surgery needs to be done. And we do not need to forget about the dangerous mimic, that if there are focal neurological deficit, if there are findings in the CSF that are abnormal, then it might be something other than IH, which can be confirmed on MRI, and the management would be different. Thank you.